In this presentation, I will talk about the endodontic treatment step-by-step procedure. To do any endodontic treatment procedure for a DZ, for a tooth with irreversible pulpitis or pulp necrosis, we will pass through 3 visits individually, or we may do them together in one visit, which are the access cavity preparation, the cleaning and shaping of the root canal system, which is also known as the instrumentation visit, and finally the obturation of the root canal system that has been cleaned. The visit number 1, which is the access cavity preparation visit, in which we will do 10 steps. Step number 1 is the diagnosis of the patient by asking the patient about the pain that he has. Generally, the patient will say that he has spontaneous pain during day or during his sleep, and continuous pain that will persist after the removal of the stimulus. And when we examine the patient, we will mostly see that there is some pain on percussion, vertical or lateral percussion to the tooth, and we may see an abscess or swelling around the apex of the tooth. On the x-ray, we will see sometimes that there is a widening of the periodontal ligament space that is present apically. After that, we will give the patient anesthesia, and after that we will remove the enamel and dentin according to this upper picture, which is we will remove the enamel and dentin in the upper incisors in a triangle shape, and that is to remove the pulp horns also of the pulp chamber, because you guys have seen that some patients, after doing the endodontic treatment, they will have their teeth be black and or gray, and that is because the dentist did not do the access cavity preparation well, and didn't remove the coronal pulp tissue, and that pulp tissue in the pulp horn area has blackened the tooth and made it gray. So that is for the upper incisors. For the other anterior teeth and premolars, as you can see here in this picture, it is oval in shape. For the upper molars, it is triangular in shape, and that triangle is located mesially, with its base located towards the cheeks and its apex is located towards the palate. For the lower molars, the same is here, and the base of the triangle is located medially, and the apex of the triangle is located distally, or it may be trapezoidal in shape, or it may be oval in shape, so that the lower molars have 3 possibilities: either a triangle or a trapezoid when there are 4 canals, or an oval access cavity preparation when there are 2 canals in the lower molar. That was the removal of the enamel and dentin outline form. After that, we should remove the pulp chamber roof, and as you can see here in these middle pictures to the left, we should remove the roof of the pulp chamber until we can see this gray or dark part of the tooth, which is the white part of the tooth, but because it is surrounded by bone, so that it becomes dark. Okay, so that we should notice that dark shadow and in the tooth, in the access cavity perforation, and we should see these connecting grooves that connects the root canal orifices. Okay, this is the correct preparation of the pulp chamber. After that, we should remove the pulp tissue by using the barbed approaches, and after that we should do irrigation. Then we should determine the length of the canal, and that is by inserting a file on 20 millimeters according to a specific reference point. That file should be size 10, and then we take an x-ray, and according to that x-ray, as you can see here in this lower picture, we will add or subtract from the length the 20 millimeters that we entered. But I want to indicate here to something, which is it is not always that the file will reach the radiographic apex, and that is because of the normal anatomy of the root canal system. As you can see here in the lower picture A, there is something called as an apical constriction, and another thing that is called as an apical foramen. The file may stop at the apical constriction, which is located a half or 2 millimeters away from the apical foramen, which is also known as the radiographic apex. Okay, so that when the file does not reach the radiographic apex or the apical foramen, that is normal, and that is the working length that we should end our instrumentation at, and we should do our obturation too. Okay, after that we should determine the width of the canal by inserting the subsequent bigger files until we have a resistance. The file that has a resistance, that means it is the file that represents the size or width of the apex, and that file is called as the initial file. That will be the first file that we will begin our instrumentation from during the next visit. Okay guys, after that the pulp canals should be filled with a medicament if the periradicular tissues were diseased, if we have an abscess, if we have a pus in the root canal system, or periradicularly, if the patient has pain on percussion or there's a periradicular lesion, the root canal system must be filled with a medicament so that the periradicular tissues can heal properly. And after that we should put a TF and instruct the patient that he should not eat on it for 24 hours, and then dismiss the patient. So that, as a summary, during the visit number 1 we should do the diagnosis and be very sure that the patient needs an endodontic treatment. Then we anesthetize the patient. Then we should remove the enamel and dentin according to a specific forms, outline forms. Then we should remove the pulp chamber roof, and be careful in that to have a very good access to the root canal system. And then we should remove the pulp tissues and then irrigate, and then we should determine the length of the canals, and then we should determine the width of the canals, so that in the next visit we can have the proper instruments with the proper length and width to clean and shape and finish the canals. And then in the other and third visit, obturate that canal according to that length and width correctly. After that, we fill the root canal system with a temporary medicament material that will enhance the healing procedure in the periradicular tissues, and then dismiss the patient. During the next visit, which is the visit of the root canal system cleaning and shaping and finishing procedure, we will do a quick history and exam to the teeth, and specifically the tooth that is intended. We will remove the temporary filling, and then we will do three things. The first thing is to widen the canal orifices, and that is called as the coronal pre-flaring procedure. That thing is done by using specific burrs known as the Gates-Glidden burrs, and then we should open the way for the files that will clean, shape and finish the canals, which is known as the establishment of a gliding path, and that is done by using files number 6, 8, 10, 15 and 20 from the ISO system, as you can see them in this picture. And then we will do the cleaning and shaping and finishing procedure to the root canal system by using subsequent bigger files, which are files number 25, 30, 35, 40, etc., until we get a clean dentin chips on the apex of the file. And at that point, the apex or the apical third of the tooth root canal is clean, and then we can go back 1 millimeter but with a bigger size for 3 times. For example, if we have the clean dentin chips at the apex of the file as size number 40 with a working length 20, so that the step back technique or the apical coronal technique or the ISO technique says that we should use file number 45 but on a working length 19, then file size number 50 on a working length 18, and then a file size number 55 on a working length 17. Okay guys, that is the step back technique or the ISO technique. Of course, between and before shifting to the next file, we should do the irrigation. Guys, the irrigation is the most extra important step in the root canal treatment procedure for me, because during my practice I have seen that okay, the access is very important for you, for your back, for your muscles, because it will facilitate the work. The instrumentation and the cleaning are very important, but because we use the rotary systems now, we are not totally sure that every single part of the root canal system is totally cleaned and shaped. And of course, the obturation, we can see during our practice that there are some gutta perchas that are over the apex or under the apex by 3 and 4 millimeters, and all of these situations are successful. But when the irrigation is bad, you will have a failure in your endodontic procedure. So that the instrumentation is very important. You should irrigate between the files to prevent the fracture of the files, because the irrigation will make the gliding path and facilitate its happening, and it will also clean the things that you cannot clean, for example the accessory canals, etc. And after doing the coronal pre-flaring procedure, establishing the gliding path, and cleaning, shaping, and finishing the canals, you should put the intracanal medicaments if the periapical tissues are still diseased. Then put a TF, instruct the patient not to eat on it for 24 hours, and dismiss the patient. Here I want to indicate for the coronal apical technique. In a moment I have mentioned the apical coronal technique or the step back technique, but now I want to mention the coronal apical technique or the step down technique, which is used by most of the non-ISO systems or the rotary systems. For example, the famous ProTaper system by Dentsply Sirona uses the following files to establish that. For the pre-flaring, coronal pre-flaring procedure, when we used to use the Gates-Glidden bears, here the SX file, as you can see its picture to the left, will do the work of the Gates-Glidden bears. The SX file will do the work of the Gates-Glidden bears, and then we will use the shaping files 1, S1 and S2 to shape the root canals and prepare the coronal part of the canals with the F1 file, which will finish the root canal system and clean the apical and middle parts of the canal. But it has been seen that the S1, S2 and F1 files are not enough, so that they have added the F2, F3, F4 and F5 files for the bigger canals, so that you should use the SX, S1, S2 and F1 files, and if the canal is not cleaned properly, you may shift to use the F2, F3 and F4 and F5 files. After the completion of the instrumentation procedure, we will shift to the last visit, which is the obturation procedure. Again, we will do the history and examination of the intended tooth, and here the examination and history taking are the most important ones from the previous two visits, because in this visit we should be totally sure that the tooth has no pain on percussion and the periradicular tissues are totally healed, so that we can obturate, because we cannot obturate on a diseased bone. Okay, after that we will remove the temporary filling and check patency by inserting the file, the master apical file that we had during the last visit, and that it brought us the clean dentin chips. And then we will do the final cleaning and sterilization of the root canal system by the irrigation with the sodium hypochlorite, and then EDTA, and then a saline, normal saline solution, and then drying the root canal system. After that, we will put the master apical file, or the master file, or as I call it as MAC. It is famous by that name, so that we should put the MAC and check its tag back, then the MAC and the X-ray, then the MAC and the sealer, then the MAC with accessory cones if needed. MAC and tag back, by I mean by that is that we should feel some resistance when we put the MAC in the root canal and try to remove it. We should feel some resistance to that removal. That is the tag back. Okay, we should ensure that we have a tag back in the cone before sealing it. After putting the MAC and having a tag back, we should take an X-ray and ensure that the MAC is in the correct position behind the radiographic apex, either a little bit behind it, or it is possible to be behind it a half millimeter or 2 millimeters, and that is normal. After that, we will put a sealer with the MAC and seal it and spread it if it is a called lateral compaction technique, and add accessory cones accordingly. After that, we cut the excess with the level of the canal orifice, and then we put the permanent filling over them. Not directly, but we should put a glass ionomer cement, then the permanent filling. That was the summary for the obturation procedure and the 3 visits of the endodontic treatment procedure. And as I have said before, we may do them separately if there is a periradicular disease, or we may do them collectively in one visit. These 3 visits might be done collectively in one visit if the periradicular tissues were healthy and there was no bone disease. We can treat the tooth in one visit. Here I want to indicate to some notes that to open the canal, if during the establishment of the gliding path procedure, we use the Glock widening technique. To clean, shape, and finish the canal, we use the reaming, the filing, and the quarter turn filing. To clean, shape, and finish the big canals, we use the circumferential filing. The irrigation, as I have said, it is one of the most important things that should clean the debris, both soft and hard, and the organic and non-organic hard debris. And it should glide the canals and kill bacteria, and all of these things, except for the removal of the non-organic hard tissues, is done by sodium hypochlorite, so that the sodium hypochlorite is the best irrigant that you may use in association with EDTA, which will remove the non-organic hard debris. Finally, the irrigation should be done with the irrigation needle that should not be wedged, and the syringe of that needle should be pushed passively, not forcefully. Thank you for this nano construction of the world by listening to this presentation. Always try to know, spread knowledge, and construct the world. Be kind to one another, because life is not short but it is limited, and that is for the greatest benefit to the humankind.